Person, sir, respected seniors, and dear friends. Today's CCR is of Department of Urology, and I am presenting brief overview of our department. The Department of Urology established independently in 2009. Before that, urologist was working with the Department of General Surgery. Initially, in the department, only single consultant. Now we have a team of 7 consultants with 2 urology units. Our renal transplant program started in 2012. MCH urology program started in 2016 with initial intake of 1 seat. Since 2020, we have 6 residents per year, so at a time we have 18 residents. We have 3 dedicated modular operation theatre working full time on all working days. We have regular academic activities in the form of seminar, case presentation, general club, inter-departmental meeting. We are giving sufficient hand-on training, surgical training to our residents under supervision, so that after passing, they practice independently without joining other institute as a fellowship or SR. This is our teaching faculty, which consists of 1 emeritus professor, 4 professors, 1 associate professor, and 1 assistant professor. We are regularly conducting camp visits, case presentation, ward rounds. We are regularly attending conferences, workshops. We are regularly organizing a skill lab intro training for our residents. We are monthly conducting theory mock exam to assess theoretical knowledge of our students. Last year we have conducted 2nd Rajasthan Urology Master Class, which was attended by around 20 senior urology consultants and around 100 DNB and MCH urology residents from all over Rajasthan, from all private and government medical colleges. We have 30 urological ward, dedicated urology and renal transplant modular OT, dedicated kidney transplant ICU with 10 beds. In operation theatre, we have our independent CIAM, 50-watt holmium laser machine, flexible RIS scope lithotripsy machine. In OPD setting, we have urodynamic uroflowmetry machine, and Da Vinci robotic system has been incorporated recently in our armamentarium. And we are reaching to 2,400 kidney transplants, 22 cadaveric renal transplants, and we are regularly doing ABO and ABO incompatible and swap kidney transplants. We are doing all type of urology surgeries in the department, like endourology, minimally invasive laparoscopic surgery, reconstructive pediatric, uro-oncology, renal transplant, and recently started robotic assisted surgeries. Until now we have done around 110 robotic assisted surgeries, which include simple nephrectomy, radical nephrectomy, partial nephrectomy, pyeloplasty, VVF repair, robotic assisted radical prostatectomy and radical cystectomy. We are performing all donor nephrectomies by laparoscopy, and our future plan is to perform robotic assisted renal recipient surgery. And monthly we are doing around 250 surgeries per month, from which around 150 are major surgeries. This is our 5-year data, and every year our surgical procedures are increasing. In the department, we have around 67 publications in different national and international journals. Now I will invite our resident Dr. Gaurav to present today's CCR.
Sir, good morning dignitaries, good morning esteemed faculty and fellow doctors. Today I am going to present my CCR about a 20-year-old male who presented to us with bilateral flank pain since 7 days and fever and vomiting since 3 days. So patient was apparently alright 7 days back when he first felt bilateral flank pain, which was more on right than left. It was sudden on onset. It was colic in nature, mild to moderate in intensity. It was non-radiating, no aggravating factors or relieving, and was relieved on taking medications. A patient also complained of high-grade fever of 101 degrees Fahrenheit, which was sudden in onset, intermittent. It was associated with chills and rigors. For last 3 days, patient complained of vomiting, which was postprandial. It was sudden in onset, non-bilious, non-projectile, and was associated with flank pain. Negative history: there was no history of any lower urinary tract symptoms. There was no history of stone, burning, micturition or hematuria. There was no history of Weight loss, there was no history of back pain or trauma. There was no significant past history. In personal history, patient had no history of tobacco, alcohol or consumption. There was no history of any drug allergy. On examination, patient was conscious, cooperative and oriented to time, place and person. His pulse was 105 beats per minute. His blood pressure was 110 by 70 mm of Hg. His respiratory rate was 18 breaths per minute and his temperature was 101 degree Fahrenheit. There was no pallor, no icterus and no generalized lymphadenopathy. The other systemic examinations were normal. So on per abdomen examination, on inspection, abdomen was flat, symmetrical with no visible scar, distension or pulsations. The umbilicus was centrally placed and inverted. There were no visible peristalsis or engorged veins. On palpation, the abdomen was soft, non-tender. There was a palpable mass of 7 into 5 centimeter in hypogastric region with irregular margins firm to hard in consistency. Lower border of mass could not be reached. There was no organomegaly. The hernial sites were normal. On percussion, dullness was present over hypogastrium. On rest of the abdomen, there was tympanic node. On auscultation, there was normal bowel sounds present and audible in all quadrants. There were no bruit heard over the abdominal aorta or renal arteries. On genital examination, the external urethral meatus was normal and bilateral testes were normal. On DRE examination, there was no anal tags, no fissure or no signs of sinus. Anal tone was normal. There was no mass felt and the prostate was flat. There was no bleeding per rectum. So now I would like to summarize my case. A 20-year-old male who presented with bilateral flank pains in 7 days, fever and vomiting since 3 days. On examination, there was a large hypogastric mass of 7 into 5 centimeter, palpable with irregular margins and firm in consistency. So now I would like to ask my fellow colleagues what could be the possibilities. So, anyone? Yeah. Okay. Anyone else? Okay. So as
अगर ये elderly gentleman होता say 70 years old, what would have been your first possibility? Smooth mass in the hypogastrium, lower border not reachable. What would be your first possibility? This is a physician asking the surgeon the question. Distended urinary bladder, right? That would be your first possibility. Yes. Correct?
So, when the lower border is not palpable, it cannot be defined. It is arising from the pelvis,
yes,
right? So, in the DRE, one would expect you to look whether it is palpable on DRE,
yes, sir,
rather than looking for fistula, fissures, etc.
Sure, sir. Thank you, sir.
Just one small comment for everybody.
Yes, sir.
Last time also I had mentioned it. For all official and scientific purposes, the temperature is always to be mentioned in Celsius and not in Fahrenheit.
Okay.
Fahrenheit is meant for informal and unofficial communication, but official and scientific is all Celsius as far as India is concerned. In the US and Canada, Fahrenheit is the official one, but in India it's still Celsius.
Sure, sir. Thank you, sir. So, to looking up the possibilities, we could suspect 3 major reasons. It could be either infective or obstructive or neoplastic. So, looking up to the infective causes, it could be acute pyelonephritis, acute prostatitis, chronic urinary retention, and in obstructive causes, it could be a bladder outlet obstruction due to stricture urethra, meatal stenosis, a posterior urethral valve, urolithiasis. And looking up to the neoplastic causes, it could be a pelvic mass or bladder. So the patient baseline investigations were done. The total leukocyte counts were raised, which was 17,300 microliters, and patient serum creatinine was also raised, which was 4.9 milligram per deciliter. Patient urine routine showed RBCs of 10 to 15 of high power field and WBCs of 40 to 50. The LFTs were normal. The patient urine culture was sent and it was suggestive of Pseudomonas aerogeneza. Patient got his USG done outside, which was suggestive of bilateral moderately dilated pelvic calyceal system with dilated upper ureter and vesico-ureteric junction. The bladder showed free floating echoes of bladder with a thickness of 3.4 mm. There was a large solid cystic heterogeneous mass, which was approximately 11.2 into 12.4 into 9 centimeter. Mass was inseparable from posterior bladder wall, compressing both vesico-ureteric junctions. Patient also had CT done, which would be explained further by our colleague from radiology department. So this patient was admitted as he has raised counts and increased creat, so we admitted him and we started IV fluids and empirically antibiotic was started. Patient was planned for cystoscopy and bilateral retrograde pyelogram. So patient cystoscopy was done, which showed us the urethra was normal, bilateral ureteric orifice could be seen. There was a mass which was bulging on the posterior bladder wall on cystoscopy, and we were not able to pass our guide wire into the left ureter, which I'll explain in the retrograde pyelogram. So on the right side there was dilatation with mild distal narrowing, no filling defect was noted on the right side. On left ureter it was dilated with severe distal narrowing. The guide wire and contrast could not be negotiated through it. As we can see in the first picture, the DJ stenting has been done, and on the left side its left percutaneous nephrostomy was placed for this patient. So the further course after placing the DJ stent and percutaneous nephrostomy, patient bilateral flank pain resolved, fever was subsided over a period of 1 week, no further episodes of vomiting, serum creatinine decreased to 1.3 mg per deciliter, the TLC counts also decreased. The daily routine output was 2.5 liters, and then CECT abdomen and pelvis was planned. So now I would like to call my colleague from radiology department, Dr. Abhijeet, who will...
Good morning everyone. Thank you Dr. Gaurav for calling me upon the stage. I will be discussing the radiological aspect of this case. So this 20-year-old male patient was referred to radio-diagnosis department from urology department with previous ultrasonography report and non-contrast CT scan which were reported outside of the hospital. We did contrast enhanced CT scan for better tissue enhancement and vascular assessment. So these are the axial cuts of the non-contrast CT scan on the left side showing mass lesion, and right side we can see contrast enhanced CT scan where we can see the heterogeneous enhancement of the mass lesion with cystic necrotic component in central compressing the urinary bladder. So these are the axial and sagittal cuts of contrast enhanced CT scan showing large heterogeneously enhancing mass lesion measuring approximately 14 into 11 into 11.5 centimeter in anterior posterior, transverse and craniocaudal diameter respectively, with central hypodense area of cystic necrotic area of the mass lesion. In this sagittal section of contrast enhanced CT scan, we can see the mass is closely abutting the urinary bladder from the posterior aspect, compressing and displacing it anteriorly with loss of fat planes. There is no obvious luminal infiltration is noted. On the right side, we can see in this axial section image, the mass is compressing sigmoid colon and displacing it in the left hemipelvis, and no obvious luminal infiltration is noted. Bilateral lower ureters were not separately visualized, probably due to encasement and compression, causing the upstream dilatation of proximal ureters and pelvic calyceal system as seen in the next image. In the coronal section image, we can see the bilateral hydroureteronephrosis. Note is also made of double J stent which is seen on the right side of the patient, and percutaneous nephrostomy catheter which is seen on the left side of patient. Correlating it with the 3D bone reconstruction image, we can see the double J stent as marked by the red arrow seen on the right side of the patient, and percutaneous nephrostomy catheter which is seen on the left side of the patient marked by the pink arrow. So these are the axial sections of the contrast enhanced CT scan. On the left side we can see aortocaval and left para-aortic subcentimetric lymph nodes measuring approximately 7 to 8 mm in short axis diameter. And in the second image we can see minimal fluid collection is seen in pelvis. So to summarizing the radiological findings of this 20-year-old male patient, a heterogeneously enhancing mass lesion approximately 14 into 11 into 11.5 centimeter with cystic necrotic areas seen in pelvis, displacing and compressing the urinary bladder and sigmoid colon and encasing the distal ureters with bilateral proximal hydroureteronephrosis. Subcentimetric lymph nodes in left para-aortic and aortocaval region with minimal pelvic ascites. So we made a provisional diagnosis of likely malignant etiology with a query of mesenchymal origin. Possibility of desmoid tumors appear less likely. Thank you everyone. Now I would like to invite Dr. Gaurav on the stage to take this case further.
Thank you, Dr. Abhijeet. So as the patient's CT was done and the baseline investigations was done, so patient was planned for percutaneous biopsy, which was suggestive of small round cell Ewing sarcoma, and patient PET CT was also planned to stage. So the oncopathology.
Malignant neoplasm.
Malignant, yes, sir.
You never diagnose just on a core first report.
Yes, sir.
Ewing sarcoma, no? Malignant round cell tumor.
Sure.
What's the name? Pathology.
And sir, this will be discussed by the oncopathology department in further slides, sir.
The patient was referred to the Department of Nuclear Medicine for baseline PET CT. This is the MIP image, maximum intensity projection image of the FDG PET CT, showing physiological uptake in the brain, heart and liver and spleen, with a large abnormal area of radiotracer uptake in the pelvic region, bilateral hydroureteronephrosis and left PCN tube in situ. These are the corresponding axial and sagittal fused PET CT and CT images showing peripherally FDG avid, large lobulated mass lesion measuring approximately 13.7 by 10.0 by 13.0 centimeters with SUV max of 15.6 with internal necrotic area. The mass is noted in the retrovesical region in the pelvic cavity. The mass lesion is crossing the pelvic brim, reaching up to the mesentery, causing mass effect over the mesentery and the adjoining pelvic structures. The sagittal image shows that the mass lesion is closely abutting the lower lumbar vertebra and the sacrum without any cortico-erosive changes. These are the corresponding coronal fused PET CT and CT images showing that the mass lesion is compressing over the distal bilateral ureters with resultant bilateral hydroureteronephrosis, right degestant in situ, and the bilateral pelvic muscles and prostate are free from the mass lesion. To summarize, the findings are peripherally FDG with large lobulated mass lesion with internal necrotic area in the retrovesical region of the pelvis without any evidence of local or distant metastasis.
So can you go back 2 or 3 slides? Yeah, this one. Next. Yeah. So I think one small comment for everybody. When you have a lesion this size, you can see that there is a very large necrotic area in the center. And if you're doing a core biopsy and your needle goes over there, then you will not get representative tissue, and you have to do it multiple times, and the patient gets really, upset. So many times we do a PET scan before the diagnosis of malignancy, and then target to do the biopsy from the active areas, right? Most active areas. And many times, and our center is one of the few centers where we are doing PET guided biopsies also. So just for the information of everybody, right?
Now I would like to call upon Dr. Kanupriya from Department of Medical Oncology to further discuss the case.
Good morning all teachers and all present. I am Dr. Kanupriya Bector, Senior Resident from the Department of Medical Oncology. So now to take this case further, to summarize till now, we know that we have a 20-year-old male who has been diagnosed with Ewing sarcoma, a retrovesical mass, non-metastatic disease, post right-sided degestanting and left-sided PCN in situ. Now since this case was discussed in a multidisciplinary tumor board which comprised of medical oncology, team of surgical oncology, radiation oncology, Department of Urology and Department of Reproductive Medicine. Now since Ewing sarcoma is a curable disease and also a systemic disease, so decision was made to start the patient on neoadjuvant chemotherapy, which means to give chemotherapy before any local form of treatment, which could be surgery or could be radiation, in view of preventing micrometastasis. Now this chemotherapy regime is known as VAC-IE regime, which comprised of 5 chemotherapeutic agents: vincristine, doxorubicin, cyclophosphamide, alternating cycles with ifosfamide and etoposide, given every 3 weekly. We usually give 4 cycles and then we plan for an assessment. At this point of time, I would like to make a special mention on the impact of chemotherapy on fertility. Now the chemotherapeutic agents which are used in this regime, mainly cyclophosphamide and ifosfamide, they have a high risk of causing infertility, which means more than 70% chances of infertility are there. Now, since this patient was a 20-year-old male in the reproductive age group, so fertility was a major concern. So for fertility preservation, this patient was referred to the Department of Reproductive Medicine. But due to personal and family decisions, it was not done. The patient was then started on chemotherapy. In between the cycles of chemotherapy, he had persistent fever and UTI, which was managed with the help of urology department. Now, baseline investigations were done at all the cycles, and after completion of 4 cycles of chemotherapy, a whole body PET CT was done for response assessment. I would now like to call upon Dr. Lakshmi to discuss these PET CT findings.
Thank you, Dr. Kanupriya. The patient was referred to the Department of Nuclear Medicine for response evaluation. These are the MIP images of pre and post chemotherapy. This shows that the significant decrease in the FDG uptake in the pelvic region, resolution of bilateral hydroureteronephrosis, removal of the left PCN tube, and Foley's catheter in situ. These are the corresponding fuse PET CT and CT sagittal images showing there is decrease in the mass lesion, FDG uptake, and extent of the lesion from 13.7 into 10.0 by 13.0 centimeters to 9.3 by 5.5 by 7.5 centimeters, and FDG uptake from 15.6 to 4.6 with residual mass region predominantly showing necrotic component. These are the corresponding coronal and axial images showing decrease in the FDG uptake size and extent of the lesion with resolution of bilateral hydroureteronephrosis. To summarize, overall scan findings are suggestive of partial response to treatment based on the response evaluation criteria resist and persist without any appearance of new FDG-availed lesion. Now I would like to invite Dr. Gaurav from Department of Urology.
Thank you, Dr. Lakshmi. So as it was discussed, during the course of chemotherapy, the patient experienced multiple episodes of febrile urinary tract infections, which were managed conservatively by catheterization, IV antibiotics, and anticholinergics. After 6 weeks, a right DJ stent change was performed, and left DJ also could be placed as the tumor was downstage and regressed. So we were able to place DJ this time in the left side, and patient was PCN free. Then patient was planned for surgical resection, and the family were explained about the possibilities of bilateral ureteric reimplantation. So operatively, after pre-anesthetic workup and taking informed consent, surgery was planned. A lower midline laparotomy incision was given. The urinary bladder was mobilized after ligation of supravesical pedicle. The mass was identified in retrovesical space, and it was compressing bilateral lower ureters and densely adherent to urinary bladder. During the dissection of pelvis, there was only cerebral tear but no major bladder injury. Mass was dissected from surrounding structures and preserving pelvic plexus. Both ureters were identified by palpating DJ stents and were safeguarded. The mass was removed in toto and intact to the capsule. So after removing the mass, we did bilateral pelvic lymph node resection. Laterally it was genitofemoral nerve, medially it was the ipsilateral ureter, and cranially it's bifurcation of common iliac and quadratus endopelvic fascia. So the lymphatic tissue was separated from common iliac vein, an artery, and obturator nerve. The obturator nerve was preserved. The hemostasis was achieved and drain was placed. There was very minimal loss of blood. Surgery went uneventful thanks to the anesthesiology department for the help. Total time of surgery was around 3 hours and 30 minutes. The patient was shifted to ward, and his specimen was sent for histopathologically, which will be discussed further. So after shifting to ward, the post-operative course of patient, on post-operative day 1, the patient was ambulated and he was orally started. On day 2, he was started on soft diet. Day 3, patient's Foley's and drain was removed as he was stable. On day 4, patient was planned for discharge and was stable. Then patient was called on day 10 for follow-up. On first follow-up, his suture line was completely healthy, so all the sutures were removed. Then patient came on day 21 for removal of DJ stent. After that, there were no episodes of any UTI. after removing registance of fever. The patient's histopathological report was reviewed in tumor board, and adjuvant radiotherapy and chemotherapy was planned. So now I would like to call Dr. Kusha Sharma from Oncopath to discuss about the immunohistochemistry and the
So one quick question to you: could this have been done robotic surgery?
Yes, sir, we could have done, but this case was before the robot came to our.
Thank you, Dr. Gaurav. Good morning, respected teachers, faculty members and colleagues. I'll be discussing the histopathological aspects of this case. So initially a baseline USG guided biopsy was done from the pelvic mass, which on histopathology revealed a malignant round cell tumor. IHC marker study was performed for this case, and the tumor cells were positive for NKX 2.2. So NKX 2.2 is a fairly sensitive and specific marker for Ewing's sarcoma. The tumor cells were negative for desmin and myogenin, which ruled out the possibility of a rhabdomyosarcoma. NSC was also negative in the tumor cells, which ruled out the possibility of a neuroblastoma. So the final impression which was given, Ewing's sarcoma. Subsequently, we also received a wide local excision specimen of the pelvic mass. The entire specimen measured 8.5 into 5.5 into 4 centimeter. The tumor measured 8 into 5 into 3.8 centimeter. The tumor was seen infiltrating into the adjacent fibroadipose tissue. We employed the grading system, that is the French Cancer Center grading system, FNCLCC, and a grade of 3 was given for this tumor. The post-NACT effect was seen in the form of necrosis, which was seen in more than 50% of the tumor area. 4 lymph nodes were identified in the specimen, and all of which were negative for malignancy. So the left-hand side image is a scanner view of the H&E stain section, which shows tumor cells which are infiltrating into the adjacent fibroadipose tissue. The second image is showing the predominant areas of necrosis which were seen, occupying more than 50% of the tumor area. This is a significant post-chemotherapy finding which we found. The right-hand side image is a higher magnification of the viable tumor cells, which are round to ovoid in shape and have got clear cytoplasm and are arranged in sheets and clusters. So the final impression which was given, Ewing's sarcoma, and a pathological staging was done, that is YPT2N0.
Good morning, everyone. Taking the case forward, the case was discussed and reviewed by the multidisciplinary tumor board. However, post-operative radiotherapy was not routinely indicated in all cases of Ewing's, but however in this case, due to the closed margins of 1 mm reported on the histopath report and the aggressiveness of the tumor, post-operative RT was considered as the optimal course of treatment. However, due to the location of radiation, the pelvis, infertility becomes a major concern. So the patient was referred to the Department of Reproductive Medicine for fertility preservation. After counseling and discussion, patient and family decided not to preserve fertility.
Just a comment here for the Department of Reproductive Medicine that if the proper counseling is done for the male patient, preserving the semen is not a big thing. So proper counseling for the family, for the patient is very much necessary. I think we have not pressed for it. Having just freezing the semen, 2-3 samples of semen before starting even adjuvant, neoadjuvant chemotherapy or radiotherapy would have been best possible, and you can preserve it for lifelong. In female, yes, it is sometimes a problem, but in the male, there should not be any problem. And this is part of the oncofertility, isn't it? So there is quite a lot of social blocks, sir. One senior gastroenterologist of the city, his son, a medical student, Hodgkin's lymphoma, हमारे पास treatment के लिए आया, खूब counsel किया उसको कि semen preservation कर ले. So the boy was so embarrassed in front of his father. He said कि नहीं कुछ नहीं, मेरे को treatment शुरू करो जल्दी. अकेले से बात कर लो सर, ये private चीज होती है. नहीं, we do sometime when most of the patient, the couple, they come along with their families, either in-laws or from parents, and just ask them, request them to wait outside, and or them call them on other day, only husband and wife or same person, if the male only is there, or Then you do counseling, it is perfectly all right. That is, I said it is the duty of Department of Reproductive Medicine, my department. नहीं आप रेफर कर सकते, फ्रीजिंग तो रिप्रोडक्टिव मेडिसिन वाले करेंगे.
Yes.
करना चाहिए.
Close to us. We also explained, but boy was very reluctant.
आपने फादर के सामने किया होगा एक्सप्लेन. We also made that same mistake.
Appropriate informed consents were taken before initiating treatment. So a radiation was planned. The dose of 54 grays and 30 fraction was planned at the rate of 180 centigrays per fraction, 5 fractions per week. The post-operative bed was to be irradiated using image-guided radiotherapy, and daily image verification was to be done by cone beam. Ji sir. Daily image verification was done by cone beams, CT scans. To prepare for radiation, mold and CT simulation was done. To immobilize the patient, a thermoplastic mold was created, and a CT scan was done in supine position with full bladder and empty rectum. 3 mm axial CT scans were taken. After proper alignment and position verification, fiducial markers were placed on the mold for reference. After obtaining the CT scans, contouring was done to delineate the radiation volumes. So a gross tumor volume, marked in red, was delineated. This shows the post-operative bed. A margin was given to this, a margin of 7 to 10 mm. This was given and called clinical target volume. This accounts for the microscopic spread of the disease. And to account for setup error, of margin to clinical target volume is given and is called the planning target volume. These are the contours on sagittal and coronal sections. A plan was then made. The plan was to be delivered on LINAC tubing machine using image-guided radiotherapy with daily verification by cone beam radiotherapy. A total of 9 fields of 10 MV photon energy was used. Now, the organs in this area, the femur head, bladder, rectum, bowel and kidneys, were all to be saved, and all of these organs at risk received doses much below their tolerance. Hence, the patient received very less radiation-induced toxicities. So, a dose of 54 grays and 30 fractions were delivered over 6 weeks to the patient from 21st August to 5th of October. There were no undue gaps, and there were no severe radiation-induced toxicities. All the mild toxicities were managed conservatively. Now I'd like to call Dr. Gaurav to take the case forward.
Thank you, Dr. Shivangi. So as in the course, as per the prior discussion by the tumor board, and based on the initial staging, he is currently undergoing chemotherapy. He is on regular follow-up with us. He is asymptomatic and he is doing all routine activities, and he has started doing his studies. This is the photograph of the patient, and he is doing all his activities right now. So why did we choose this case? So to tell about this case, I would tell that first of all, there are only very few case reports. There are not even case series on such kind of case. It is important because young patients, they require aggressive treatment, they require multidisciplinary team approach, and treatment intent is to be curative. So we could find just only two case reports. So to give a basic overview about the Ewing sarcoma, I would like to tell about it's a small round cell tumor derived from the neural crust. It's characterized by the fusion of translocation of gene 11/22, and primarily the tumor of bone origin, but soft tissue Ewing sarcoma is very rare, aggressive tumor, and presents with advanced disease metastasis and has a poor survival. The incidence of soft tissue Ewing sarcoma involves children, adolescents, young adults, more than 90% of cases are having disease onset between 4 to 25 years. The retroperitoneal sarcoma is relatively uncommon, and it's accounting for less than 15% of all the soft tissue sarcoma. So the patients with Ewing sarcoma, they have non-specific symptoms like abdominal symptoms, discomfort, distension, nausea and vomiting. They are usually unsymptomatic until large enough to compress or invade the surrounding tissues. For diagnosis of Ewing sarcoma, we use imaging, we use tissue biopsy, and specific stains are used to diagnose. The treatment requirement for Ewing sarcoma is a multimodality treatment which requires surgical excision, chemotherapy, high-dose radiotherapy. So the prognostic factors are presence or absence of metastasis, tumor size, extent of necrosis, and response to chemotherapy. Now I would like to invite Dr. H.L. Gupta sir to give us overview about this patient.
So these patients, some patients present with very subtle and very vague symptoms may have aggressive disease. So we should have our eyes open, because for us this case was for me, when I see this see the patient, so I took this diagnosis chronic retention with UTI, because mass was palpable. Many times this looks a bladder. Patient giving not history of urinary tract symptoms, but when we put catheter, we do sonography, it's turned out to be bladder. So we should not delay the diagnosis, because the delay will increase the morbidity. Any patient which present with bilateral obstructive uropathy with infection should need prompt decompression in the form of internal drainage like degestant, or external drainage like percutaneous nephrostomy. Because if we delay this, then patient need hemodialysis with unnecessary increased morbidity. In our department, this facility is available 24 hours, because this is aggressive disease. So we should not hesitate to take consultation with our department. Like in this case, the case is discussed in multidisciplinary tumor board, give chemotherapy. We operate and everything went well. If someone operated early, as Dr. Ajay said, then it would lead to major complications and poor prognosis. As the disease is aggressive, patient need multiple treatment, multiple catheterization, recurrent UTI. So need holistic and sympathetic approach, and we should be available to this patient and family very easily, and obviously these patients need regular follow-up. And now we extend our heartfelt thanks to the Almighty, patient, his family, the hospital administration, and our department, and our collaborative department, Department of Radiology, Nuclear Medicine, Radiation Oncology, Medical Oncology, Oncopathology, Surgical Oncology, Reproductive Medicine, Department of Anesthesiology, and a special thanks to our CCR review committee who help us to prepare this CCR by giving their precious time. Thank you.